Welcome to MedNexus and to this explainer on sickle cell anemia. Today, we're going to dive right into one of the absolute most important inherited hemoglobin disorders in all of medicine. We're going to break down the exact mechanisms of this disease, starting from the microscopic genetic level all the way up to the macroscopic clinical symptoms.
I want you to imagine something for a second. Think about your red blood cells. Normally, they're these bouncy, flexible little discs that easily glide through your tiniest blood vessels. But what if they suddenly transformed? Imagine if they changed into rigid, sharp shapes that actually actively blocked your blood flow. What exactly would happen to your body? Well, let's contrast these two states. On one side, we have our normal, healthy cells, flexible, round discs designed perfectly for carrying oxygen. On the other, we have sickle cells, rigid, crescent-shaped cells. And this simple microscopic transformation is literally the root cause of severe pain episodes, chronic anemia, and widespread organ damage. Okay, so here is our roadmap for today. We'll cover 1, the HSS genetic mutation, 2, pathophysiology and vaso-occlusion, 3, clinical features and complications, 4, diagnosis and screening, 5, treatment and management, and finally, 6, high-yield exam pearls. Let's start right at the beginning with section 1, the HBS genetic mutation. It's honestly kind of crazy when you think about it. At position 6 on the beta-globin gene, we have a single-point mutation. It just swaps out glutamic acid, which is hydrophilic and loves water, for valine, which is completely hydrophobic and repels water. It is literally just one single amino acid substitution out of hundreds. So the absolutely crucial point here is that this single tiny swamp transforms normal, healthy hemoglobin A into the mutated hemoglobin S. That one structural change completely alters how the hemoglobin behaves inside the red blood cell, and it sets the stage for the entire disease. Moving right along to section 2, pathophysiology and vaso-occlusion. This mutation triggers a massive domino effect. It all starts with step 1, deoxygenation. When oxygen levels drop in the blood, that mutated hemoglobin S starts to stick together, or polymerize. This polymerization physically stretches and distorts the red blood cell into that fragile, rigid crescent shape we talked about, which then gets stuck and physically blocks your blood vessels. And that brings us to a rapid review equation you absolutely must master. Sickled red blood cells cause tiny vessel blockage, and vessel blockage equals tissue ischemia. The tissues are quite literally being starved of oxygen because the blood simply cannot flow past the traffic jam of rigid, sickled cells. Now let's look at section 3, clinical features and complications. The single most important clinical feature you've got to remember is the pain crisis. Sometimes you'll hear it called a vaso-occlusive crisis. When tissue becomes ischemic, it screams out in pain. This is not just a mild ache. It is agonizing, severe episodic bone pain that frequently brings patients straight into the emergency room. But it doesn't stop at pain, unfortunately. Because these sickled cells are so fragile, they break down easily, leading to chronic hemolytic anemia. In babies and toddlers, we often see dactylitis, which is a really painful swelling of the hands and feet. We also have to be on high alert for splenic sequestration, where a massive amount of blood suddenly pools in the spleen, causing a life-threatening drop in blood pressure. Plus, because the spleen gets damaged over time, these patients face a much higher risk of severe infections due to functional asplenia. Over time, these repeated vaso-occlusive events take a really heavy toll on the body. Patients are at risk for life-threatening complications like acute chest syndrome, which is essentially a sickling crisis inside the lungs. They're also at risk for strokes from blocked cerebral vessels, avascular necrosis where bone tissue in the hip literally dies, and chronic, progressive damage to the kidneys, liver, and spleen. So with such high stakes, section 4, diagnosis and screening. Early newborn screening is absolutely vital. In fact, in a lot of places, it's just a mandatory part of the heel prick test right after birth. If we take a look under the microscope at a peripheral blood smear, we will visually see those classic, rigid, crescent-shaped sickled cells. We'll also spot target cells, which look exactly like they sound. They have a dark center resembling a bullseye. But the definitive gold standard test you need to know is hemoglobin electrophoresis. This test separates out the different types of hemoglobin based on their electrical charge. It officially confirms the diagnosis by proving the presence of the mutated hemoglobin S while showing that normal hemoglobin A is either severely reduced or entirely absent. Let's move to Section 5, Treatment and Management.
Now, hydroxyurea acts as a massive medical game changer here. It works by tricking the body into producing more fetal hemoglobin, or HbF. The beauty of this is that fetal hemoglobin doesn't polymerize the way HbS does. So by ramping up the HbF, we dramatically reduce the overall sickling effect inside the blood vessels. It is a completely brilliant physiological workaround.
Beyond hydroxyurea, we have to support our patients super aggressively during a crisis. We use heavy IV hydration and oxygen to reverse the sickling triggers, along with really strong pain management, often requiring opioids. And because their spleens are non-functional, strict vaccination protocols are critical to prevent fatal infections. Finally, for some eligible patients, a bone marrow transplant actually offers the only potential curative therapy we currently have. Okay, time to bring it all together with Section 6, High-Yield Exam Pearls.
Let's rapid fire through these. Memorize these 4 facts immediately. The mutation is always a glutamic acid to valine swap. The inheritance pattern is autosomal recessive, meaning you need a mutated copy from both parents. The most important frequent crisis is the vaso-occlusive pain crisis. And finally, fetal hemoglobin, or HbF, acts as your ultimate protective factor against sickling. Oh, and you've got to remember the specific triggers that actually set off that initial deoxygenation cascade. Things like sudden hypoxia from high altitudes, systemic infections, poor hydration, extreme cold exposure, and physiologic acidosis. Counseling patients to avoid these triggers is literally half the battle in managing the disease day to day.
To wrap things up, sickle cell anemia is a profoundly impactful disease. As this quote perfectly summarizes, just a single amino acid substitution radically transforms flexible red blood cells into rigid sickle shapes, leading to immense pain and systemic complications. But the really great news is that despite the severity of this classic genetic disorder, modern therapies like hydroxyurea and advanced supportive care are significantly improving both the quality of life and the long-term survival rates for these patients.
And that does it for our explainer on sickle cell anemia. I really hope seeing the flow from the genetic mutation straight to the clinical symptoms made this complex topic crystal clear for you. If it did, be sure to like, share, and subscribe to MedNexus for more high-yield medical education. Drop a comment below. What fascinating medical topic should we break down and visually explore next? Thanks for watching, and keep learning.